OT. I said, "No, I'm there in the complex himself. Just you go ahead."
I think the case has already started. Nisar, you are there or the Dr. Nisar is?
Yeah.
Yeah.
Am I audible? Am I audible?
Yeah, very well.
So this is a young patient, 35 years old, who has been operated previously, 10 months back.
Okay.
For a fistula in under local anesthesia. We don't have the details about the previous surgery. Now he has a recurrent fistula.
We can see the internal opening. That internal opening that.
Yeah. Basically, that is an opening. I will just let you show you. So endo ultrasound has been done that has reported that this patient has a intersphincter fistula.
Okay, Nisar, can we go to the other OT? The another case is been done by Parvez and he's showing some complex fistula. The audiovisual, can you please shift to the Dr. Parvez OT?
Lateral retractors, Zerni's.
Gauze shifted.
This is a sort of very complex fistula having openings on both the sides. You can see that the scars on both the sides, especially.
Hello, Shekhar, can you hear me?
Yeah, we can hear you very well.
So this guy has been operated, I think, 4 times before.
Okay.
And you can see one scar here, one opening, sort of sealed up opening here, one patent opening here. Now on rectal examination, he's got, I can feel the tract here. And I can feel a horseshoe intersphincteric tract also. So bilateral transsphincteric and bilateral high intersphincteric tract. Okay. So my plan is to excise everything and then I will do a sphincter repair.
Okay. So can you start explain from where you will start?
I will start from here, this opening.
Okay.
We can also start from inside, and the opening will be somewhere around here, 6 o'clock.
Exactly.
Okay, so the opening is blocked. There's no dye coming inside, but we will go. Can we get a little head low position or table high?
As I said, many times the internal opening gets blocked and fibrosed.
See the
so
opening,
you will not be able to.
It is blocked because nothing is going inside. It's going up to here only, this much. Okay. It's working. Huh? No.
All that black pigmented area is the area suggested of external sphincter.
Can we adjust the light? Light adjust कर देना. Dark है वो. So I'm starting with the incision on this side.
Or have you injected adrenal solution?
No, I have not injected anything. They have given spinal to the patient. Spinal application.
Okay.
Saddle block has been given. Okay. So I'm starting with the dissection from this side.
Right.
And I will follow the tract. Okay. We know
that.
Where
you did you feel any induration in the direction of the fistulous tract?
Here we can't feel anything, but obviously the tract must be going there. We have right angle retractors, Jose. Right angle retractor. So if you have an opening, you are asking where to start. If you have a scar or opening, you should start from there. Then it is easy to trace the tract. If you can't feel anything outside, then you start from the internal tract, internal opening.
Say it again, please.
I said if you are asking me where do you start from.
Yes.
I said if you have an external opening or a scar, then you can use that as a landmark to start the surgery, Alice. And if you don't have anything outside, then you start from the internal opening.
Okay.
So
you get the point. If you have external opening, you can start dissecting from there and just follow the track. In case if you don't feel the induration, it means that it is going higher up in the striatal fossa. this will take, most likely it will go lead to the midline posteriorly.
Retractor આ બહુ નાનો છે, મોટો નથી, મોટો જોઈએ પડે. I'll start also from this side. There is some induration here I can feel. I will start from here also. Till they get the right angle retractor, we will start from here.
Sometimes if the track is going deep inside, you can abandon that and start from the other side. So that idea is to find the, go near the internal opening.
No, I have not abandoned. I am waiting for the right angle retractor. That's why I am starting on the other side. And ischiorectal fossa, you can be generous in cutting because there is only fat there, so we are not worried about anything. When you come to the sphincter muscle, then you can be a little conservative. But ischiorectal fossa, you can excise very generously. You can hear me, right, Shekhar?
Yeah. I think it is going deep inside.
Yeah. Yeah. See now, if you can see some. You can see this. No, the tract is opened up here. Okay, methylene blue.
Yes.
So we will inject some methylene blue from here.
So injecting methylene blue is to delineate the.
See, some fluid has come out now from
so that
here.
You don't leave anything behind.
Some fluid came out from here now. So there is a cavity basically. You can see there's a cavity. I will just extend this incision so that I can remove the whole cavity.
As Dr. Parvez has said, you can be very generous in exercising in ischiorectal fossa. There are no important structures in ischiorectal fossa except for the fat. Idea is to remove all the infected. Area.
See, this is a whole cavity here. Can you see this? So I'm going to excise that cavity.
Any recurrent cases, and there could be many iatrogenic tract could be present.
So if you go from outside the cavity, then you get a good plane. If you go from inside the cavity, then a lot of bleeding will be there. That's why I'm going from outside. So cautery is very good here. That's why the bleeding is less. So to have a good avascular field,
even that cavity is very scarred and it is not.
No, see here the cavity is opened up. Can you see this cavity is opened up here? So I'll go beyond it.
Meanwhile, on the opposite side, there seems to be high intersphincteric fistula with internal opening at 6
so you can go to Nisar if you want to that side.
So we can see the picture. I will just pass the comment so that the people would understand what he is doing.
Dr. Nisar, you are online.
Okay, Dr. Shekhar.
Yes, Nisar.
So this is the internal opening of the fistula at 6 o'clock, just inside the anal verge, right? So,
Right.
so I can feel the induration in the post-anal space. There is probably an inflammatory induration, a phlegmon there at this place. I can feel it and going laterally in a semi-horseshoe manner. So he has a
Okay.
previous scar of the surgery at 3 o'clock position. So probably it has been a semi-horse left-sided fistula. So they have drained only an abscess or done on the fistula tract half-heartedly. So now I will be just approaching this fistula through the internal opening.
Okay. So you will
So
excite the internal
it is
opening.
expected that it might be having some intersphincteric extension, right?
Right.
So I will
Your
go
hand
around.
is Nisar, your hand is coming in the way.
So I
Can you
will
ask
go.
photographer to focus on the area of dissection so that they can see what you are exciting?
Just a moment, sir. We are doing it.
Nisar, your hand is coming in the way, and ask the photographer to. So what he is doing is he is exciting the internal opening area surrounding internal opening.
Okay, okay, no
And
issue.
from there he will follow the track, which is a blind one.
आप ये पकड़ो, आप ये पकड़ो, फोर्स इसको दे दो. Plain.
Meanwhile,
plain,
if there are any
plain force
questions
देना.
from the audience,
यार,
they can
plain
ask.
force देना.
Is it fine, sir?
It's okay now.
Thank you.
इसको पकड़ो. हाँ, okay. Okay, okay, leave it, leave it.
So you can see that he is extending the whole infected anal gland containing the internal opening. And from there he will track the tracts.
Give me Ellis.
Nizar, isn't it better to inject submucous adrenaline saline solution in the submucous plane?
So I have done an infiltration of adrenaline solution, 1 ampule in 200 ml of saline.
Okay.
So this side. Now how is it? आप साफ करते जाओ ना.
Can someone throw proper light on Nisar side?
Cautery बड़ा coagulation.
Meanwhile, on Dr. Parvez side, the track seems to be going high up. I think many times it goes to the infralevator area. And from there, it enters the deep external sphincter. Let us see from where it is entering. Nisar, you are out of focus.
Okay.
We are just adjusting, sir, the camera.
Now we can see, but still it is out of focus.
Yeah, just a second, sir.
Yes.
Dr. Shekhar? Shekhar, sir. Dr. Shekhar,
Yeah.
can I have a MRI picture of Dr. Parvez's case?
Anyone asking question? I don't know. Huh? Yeah, Vijay, tell me.
Hey, can we see MRI image of this patient, sir?
Let me see, sir. If it's possible, I'll show it to you.
Yeah, please.
Okay, Parvez, can the audio visual team please shift it to Dr. Parvez's side?
First my Hello.
Parvez.
Yeah, can you hear me?
Yeah, we can hear you.
So you can see this is a big abscess cavity. Can you see this?
Yeah.
So I'm excising the entire abscess cavity, and this will ultimately lead to the tract. So normally what people do is drain the abscess or curate it. I would excise the whole thing. Can you see now? This is all abscess. This is the abscess cavity here inside. And so this is the, I'm excising this is the gluteus muscles. Can you see this? So I'm lifting it off that.
So those are the fibers of levator?
No, this is gluteus muscle, this here. This was like this actually, stuck to the gluteus muscle. I have lifted it off the gluteus muscle.
Okay. So most likely the track is going high up, right?
Yeah, this will now enter the sphincter ultimately. So sometimes the gluteus muscles can bleed. So you have to be careful with that. See, I normally prefer to do a complete resection of the entire prostate tissue, not prostate, sorry, of the entire fistula tract. Now, if I remove the entire disease, and the recurrence rates are very less, okay? You can see it is a very big.
Yeah,
Can
we
you
can
see
see
this?
it.
Yeah.
There may be I think there are 2-3 tracks seen in that.
Yeah. Since he's been operated many times before, that's why they kept the case for me, because
Meanwhile, on Nisar side, he's excising the inferior anal gland and he's entering the intersphincteric area.
I'll just speak the MRI findings of the patient Dr. Parvez Sheikh is doing.
We have the MR, we'll show it once the surgery is over.
No, the MR findings actually.
Okay.
What is the report? It's actually a multilocular abscess in the right ischioanal fossa with perilesional edema associated with a transsphincteric tract showing thin internal mucosal opening at 6 o'clock position in the mid-anal canal. And superiorly, the abscess piercing the levator ani and showing supralevator extension with internal mucosal opening at right lateral wall at 8 o'clock position. And then there is an internal hemorrhoid at 9 o'clock position just distal to the anal verge. And there is no evidence of any pelvic lymphadenopathy or free fluid.
okay. Now if you see this abscess, the entire abscess is now almost out. Now it is entering this is the external sphincter. Can you see? 1 minute. Yes. Can you see the muscle now?
Yeah.
Okay, that is external sphincter. Now what I'm going to do, I'm going to go from inside now and we'll try to connect this. Okay?
How can you identify the muscles exactly? External sphincter, internal sphincter?
I'll show. When I dissect here, I will show. Okay. Speculum, sim speculum.
See, on the opposite side, Dr. Nisar is just tracking the track. He has almost excised the whole infected anal gland. You can see the normal tissue outside the infected anal gland. That is the plane of intersphincteric groove.
Can you see this opening here? Shaker?
Yes, we can make it.
I don't know, the light is not proper, but there is an opening.
Is there any doubt about in the minds of audience? You can see that granulating area. So Dr. Parvez is also doing the same thing. He's excising the inferior anal gland in a circumferential way.
Right angle.
out.
So you can
Nani abja.
Meanwhile, Dr. Nisar is also showing a very interesting case where there is no external opening, only the internal opening was there. Now he's tracking, finding the track. which is lying in the intersphincteric area on both sides. These are also very difficult cases.
So Shekhar,
Yes.
now I'm at 6 o'clock position. I'm dissecting the anal. I'm going up to the intersphincteric space where I will show you the anal gland complex, which will come. Okay.
Okay.
I have not injected any saline adrenaline here. It's just the cautery is doing the trick. Elise.
You can see this fibrous anal gland with the surrounding normal
Can
tissue.
you see this?
Yeah.
Okay.
So it is going in the superior direction, Parvez?
Yeah, I'm going. This will be a intersphincteric. He also has an intersphincteric extension, high intersphincteric. So I'm going to be following, and somewhere down the line, this will also get opened up. I'm in the intersphincteric space now.
Yeah, actually, when usually surgeons they develop scare when they enter the intersphincteric groove.
See, this is the external sphincter here.
Yeah, because
And
the
this is the
annular
internal.
ring
This
is
is the
just
internal.
nearby.
This is the internal
Can you
sphincter.
show the annular ring by palpating it?
Anorectal ring is still high up, okay? And I can feel little induration there. That means there is a horseshoe intersphincteric here. So we will go from here and we'll come up to the high intersphincteric horseshoe. Okay.
Your head is in the way. Yeah, that's why. So it is going on the left side?
It is bilateral
on the lip?
horseshoe. It's a horseshoe intersphincteric. So on both sides. So you need to have good light. You need to have a good cautery. Then you can do a good avascular dissection. See now this tract has come here. From here, it is opening here. Okay?
Almost they're touching, right?
Yeah, this is opening here. So what I'm going to do is, I will lay open this. See, can you see my, this thing has come. Can you see this?
Yes.
Can you see the tip of the cautery?
Yeah. We can.
Yeah. So that tract, that is a tract. So what I'm going to do is, I'm going to lay open this on this side so that we'll get a better view also.
So anything less than 30% of the external sphincter you can easily cut without having any fear of incontinence. If at all there is incontinence, it is partial and time limiting, self-limiting.
Okay. મોટું આપજે.
The idea is to suture it back in place after you remove the whole track. Sometimes the fistula surgery is more daring than anterior resection, said Professor Dr. Golikar. This is one such case. Because the fear of incontinence is so severe in the minds of surgeons that they leave the tract dissection incomplete. And patient keep on suffering.
Shekhar, can you see this this side? This is the intersphincteric on that side, on the right side, on the left side rather. This is the left side of the patient. So I'm now excising the intersphincteric on the left side. Can you see this?
Yeah, we can see the track.
This one. Can you see this hard?
Parvez, can we do lift on this side? Because you can see the track.
Lift is a little difficult because you see the tract is multifold, you know. The results with lift are not as good as what I'm doing now. Can you see this hard? It's very hard.
Yeah. Yes.
So that is, this is like this. This is on the left side. Okay?
Yes.
So I'm separating it from there, moving it, put it this side.
So how to remove the fear from the mind of surgeon when you are dissecting in that area? That
See,
would tell the audience.
now this space this space is very clearly seen. This is the this is the internal sphincter. Okay? This is the external sphincter.
Hello, hall.
And this is the intersphincteric space. Is it seen well?
Nisar, just hold on for some time. We are on the very important part of dissection on
Okay.
Parvez side.
Okay.
I'll show you
Just
again.
hold on your dissection
I'll show
for
you
some
the
time.
intersphincteric space. This is the external sphincter. Okay. This is the
Okay.
internal sphincter. And this is the little intersphincteric space from where I've removed. This was like this. I removed this from there. Now this is all clean. This muscle is clean now. So this is the dissection limit on the left side. So now I'm separating the tract from there. Okay, I'm lifting it from there. See, you can see fluid as pus has come. Can you see the pus?
Yes. Again, this also seems to be high intersphincteric tract.
Yes, this is a high intersphincteric tract. I said high intersphincteric horseshoe, and there's an abscess here. Can you see this? So now, if you want, I'll keep on dissecting. If you want, you can go up to Nisar side.
Yeah. Dr. Nisar. Hello?
Yes, Dr. Shekhar.
Yeah.
Please
Now you
switch to
can
Dr.
tell us,
Nisar, please.
Okay, just see how what I dissected. So this is basically an cryptoglandular complex which was inflamed and indurated in the post-anal space, right?
Right.
So I have got this fistula right from the intersphincteric space from here. I have got it down, excised the cryptoglandular complex and the post-anal inflammatory induration. Now I am seeing the tract, right? So this tract is going to the previous scar. So this is the tract, whitish, what you call cord-like structure.
So this is also high intersphincteric going.
This is basically a
entering in the
semi-horseshoe. Semi-horseshoe, external opening is closed because of previous surgery and fibrosis. You see, I pull.
Yeah. We
pull,
can
you can see the
plugging.
puckering at this site. So
Right,
I followed this tract in an antegrade, retrograde fashion. Rather than going from the external opening, I went from the internal opening. Excised
from inside only you will excise.
Yeah. Excised the internal opening, then intersphincteric extension, cryptoglandular complex, and now I am following the tract towards the external opening, which is expected to be at 3 o'clock position. Here, you can see
Or
the
you can
dimple.
just excise at that part and just curate the distal area. Is it okay?
No, I will just I will excise right up to the, what do you call it, external opening. So you can see the puckering. I am pulling on the tract, internal opening.
So audience, any question, any doubt about your mind? This patient doesn't have any external opening. He started dissecting from the inside of the anal canal, and he has tagged down the tract from the intersphincteric groove, and the tract is entering deep part of the external sphincter. So he is going up to the end of the tract and excising it at the farthest end without leaving any infected material behind. Right, Nisar? Now we go back to the Parvez side.
Okay.
Parvez?
Okay.
Shekhar, sir.
If you see now, Shekhar, there is a cavity here up. Okay? The supralevator cavity where my finger is going now. It's a big cavity. You can see
Okay.
all
Very
this
rarely
pus,
you see
all this
this
pus
is the high
coming from there.
intersphincteric tract which is going, right, Parvez? It is going intersphincteric tract going in
See,
the...
this is the internal sphincter. This is the external
Right.
sphincter. This is the intersphincteric space, and now this is leading to the supralevator space. Okay?
Okay.
It is seen well, no? Now I'll remove this part also, disconnect this part, so that we have the entire disease in our hand then. So this is a...
Most of the surgeons wouldn't dare to do this type of surgery because it looks very horrible. But in the expert hand, he is doing in such a way that
it looks
appears
simple.
very simple for him.
Does it look simple, Shekhar?
You make it look so simple.
Now I'll disconnect this tract from here.
Again, the anorectal ring, that the fear of anorectal ring would come in the mind of
Yeah,
surgeon.
I'll show you the anorectal ring also.
Is that the area of deep post-anal space, Parvez?
No, this I'm still in the ischiagram. I want to remove this. I want to disconnect this part so that the remaining disease is still seen well then.
Can you spread it so that people would understand properly?
See, this is the cavity.
Left side cavity,
You
right?
can see this right side, right? This is the right side. Okay, the right side cavity. And
Right or left, Parvez?
this is left of the patient.
Okay.
This is right. My right is patient's left.
Okay, yes.
This is lithotomy ना थोड़ा ऊपर पुल करके ऊपर हाँ बस.
Yeah, please, just speak little loudly. See, anything about 30% you can safely cut. More than 30% below annular ring, you have to suture it back, but you have to do it very wisely, very judiciously. He has almost gone above 30% of the area. He is going to suture it back, but he is not touching the anorrectal ring at all. Below the anorrectal ring, you can cut with caution. You have to suture it back. He is almost high in the intersphincteric area.
Okay, now this is out. Okay.
Okay.
Anteriorly, more than 30% shouldn't be sacrificed. Posteriorly,
Now
you can go
see
up to 50%.
this is the anorectal ring. Okay, this.
Yeah, that is
Okay. Now
Nisar
above the
side, you
above the
can see
anorectal ring is the supralevator space. Curate scoop.
on the Nisar side, you can see that the track was, the infection spreaded from the deep posternal spaces on both sides. Internal opening was at 6 o'clock, and tracks were on the both the side. On the opposite side, one side it was on.
Biopsy
high transcriptic.
I'm just
Very well.
curating that tract. Okay.
Yeah, please.
The case the Dr. Pravez is doing, actually he is not cutting the external sphincter at all.
Yeah,
So there is
I was going between the
yes.
two. I've cut partly the external sphincter here. Okay, on this
Only
side.
on one side, on the right side of the patient, he has cut the external sphincter a little bit, but
Yeah.
on the left, he is not cutting any external sphincter.
Yes.
So there is no question of that way. But yes, of course, internal sphincter also, you should try to cut minimum possible at the anorectal ring. That is true, that anorectal ring has to be maintained. But here he has not cut the external sphincter in the midline or on the left side, so there is no question of that problem is there. So we should be clear.
Even if you cut below the anorectal ring, you should suture it back.
Yes, less than 30% you can go if already there is no compromise in the continuance of the patient. And if you cut 50% almost, you should always repair. Even few people now repair, even they have cut 30%. And beyond that, you should be very, very cautious. You should, in no condition, you should cut the anorectal ring. That should be very clear to everybody. And in female, as you asked, it's already a compromised sphincter. So even if you cut less than 30%, you should be careful and should stitch it back.
Nisar, can we, audiovisual, can we go to the Nisar side,
wash
please?
का saline wash George बने. हाँ saline है H2.
Take it, sir. Just a moment.
Yes, Shekhar.
Hello.
थोड़ो
Nisar,
Yes,
hydrogen डाल
see,
can you cut the fistula on one side and
no,
just keep it from
I
the
will
opposite
preserve the
side?
sphincter because I can just railroad this fistula tract under the sphincter. I will get it out under the sphincter and preserve
Okay.
this portion of the sphincter. Right? So this is a
Yeah, yeah.
sphincter. I will preserve this because it is easily, I can easily get it under the sphincter and take it out. Right? So this is the external part of the sphincter. This is the internal part of the sphincter. Quite unusual case. We usually don't do like this, but in this patient there was no external opening. So one would expect it, and ultrasound report was also only intersphincteric fistula. So one has to rely on the clinical findings and the local judgment, local palpation findings. So I could feel the induration here. I could feel the induration going towards the left side at 3 o'clock position. That means it was a semi-horseshoe fistula with an intersphincteric extension. So I managed to excise the tract in total. So almost whole of the tract will be out, and then I will show you the marsupialization of the wound. Right?
Right, very well done, Nisar.
Okay, I am just now इसको retract करो. All right.
Shekhar sir, just a point. For what we discussed, 30%, 50%, but once we come on table, you cannot decide what is 30, what is 50, what is 40. So what I believe is once we are cutting the sphincter, anything below the puborectalis, just repair it. So we cannot make numbers, no?
You can see the
So
tract.
better is to repair whatever you cut, and you can easily cut. No need to worry. If you are below the puborectalis, we can easily cut it without any worry.
No, Asif,
just repair it.
Dr.
Repair
Asif, it is better if you are below the dentate line, not puborectalis. If you do the division of the muscle between the pectinate line and the puborectalis, then there will be some amount of incontinence, right? So it is below dentate line you can divide. You can manage to divide the sphincter without any significant incontinence. And if you go above the pectinate line up to the puborectalis, there will be always some amount of incontinence. So, and you will have to do a primary sphincter repair.
Yes,
right?
that's my point, sir. Yes,
Yeah.
sir. That's my
So
point.
that is important.
We have to repair. We have to repair whatever we cut.
So, Dr.
Yes,
Shekhar,
below the
Dr. Shekhar,
Yes.
so this is the tract which I have excised.
Yeah, this was the intersphincteric fistula nano with
And
one
semi-horseshoe.
going
So
to
I
the
have been
transsphincteric.
able to preserve this part of the sphincter, right?
Right,
So,
right.
and this is the portion of the internal sphincter, and behind this is external sphincter.
Right.
So,
So
this is an excision of the horseshoe fistula tract in toto. So I think it is very clear, right? So I will lay emphasis on the fact that one has to rely on the local findings and the clinical judgment. Don't go by the MRI findings or the ultrasound findings, right? So
Right.
ultrasound was showing only the intersphincteric extension, then one would just excise this portion and come out. So patient would come with a recurrence within a month or two, because you would have left this much of tract. It was not apparently visible, neither it was shown by the ultrasound. Say this horseshoe tract, right? So it was there. So it would have erupted any time. So my excision is complete, fistulectomy is complete. Now I will be approximating the edges, doing the marsupialization of the wound.
Right.
So I will be doing the marsupialization of the wound to reduce the size of the wound. So it will improve the healing rapidly. The wound it will reduce the healing time and will also avoid these side pockets, right? So, and the dressing will also be easy.
Dr. Nisar sir.
Yes, sir.
A small tunnel created cranial to the subcutaneous component of the external sphincter. Yes, where you are probing now.
Yes, right.
Are you going to close this tunnel, or you are not?
No,
afraid
I will
of
leave it.
any
It will heal. It will heal by fibrosis. I will only close the skin with the subcutaneous tissue to reduce the wound.
So
that
you
will
not
close off its own, because there is nothing, what you call abnormal tissue. No abnormal tissue there. The tract is out. So this is
Agreed,
normal,
but
healthy tissue. It will close.
Agreed, but some of us are concerned about the early swelling of this small hole, and why can't we stitch this defect in the external sphincter with a PDS? Is it possible?
It
or
is
you
almost
should not
closed. It is
advocate?
possible. You can just apply a suture or two. I don't mind, but I would not recommend. No soiling will be there, because I will close.
Whether that suture stays back or every time it disrupts.
Which one? This suture?
If you approximate this small component of the external sphincter with the superficial component of the external sphincter.
No, this is only this external sphincter, and there is subcutaneous tissue, the ischiorectal fat underneath it, right? So I have not divided.
Must be the cranial component of the external sphincter after that.
Yeah. This is all external sphincter component. It is going all around. So I have not disrupted it. So this tract was going through the ischiorectal fat, right? So I have dissected the tract intact all along. I have kept the sphincter intact.
Yes,
Normally,
when we excise the tract, we must have created a hole in the external sphincter.
no, this was going under the external sphincter in the ischial. See, you can see it. There is fat underneath. You can see
Agreed,
this
sir.
yellowish.
Agreed, sir. This is the subcutaneous component of the external sphincter.
Yeah.
There must be now a gap between the superficial and the subcutaneous part of the external
Those are
sphincter.
superficial fibers. You need not to stitch them. This is a low division of the sphincter. So we need not to worry about those things. Right? So there won't be any soiling. So there won't be any infection. Because basic thing is that you have removed the diseased portion of the tract, diseased tissue. So it is all healthy now. You can see there is nothing abnormal, unhealthy granulation tissue anywhere, no fibrosis. So it is going to heal within few days only. It is going to close in few days only. Right? Once the patient will be out of anesthesia, the muscles will contract, they will come to their original position. So, right? So the cavity will contract and the muscles. So
Dr.
this is
Nisar,
also...
Dr. Nisar,
Yes,
there is no harm in putting 2 stitches there to obliterate the dead space.
Dead space, ma'am.
No, that's the space that side.
This one,
yeah.
Okay, I can put a absorbable suture there. No issue.
To obliterate the dead space.
Even that sphincter.
There is no harm. There is no harm, but I would prefer to avoid stitching that. I will show you.
So I think
now you can give me 30 silic.
It's a good idea to cut that sphincter. It's a superficial part of the band,
and
because if you keep that sphincter as it is, it will be
30. Give me wet cause.
Shekhar sir.
One
that
case.
is adhering. That is sort of.
Shekhar sir.
Dr. Professor Nisar, people have little apprehension about keeping the wound open. Can you suture that mucosa to the cutaneous part and close the wound?
It will be under tension. I would not. I would not like that. It will be under tension, right? Because we have excised a portion of the skin here. So why should you? It will take around maybe 3 weeks at the most, 3 or 4 weeks, and it will be without tension. So and there will be drainage also. So I would not advise that thing.
Just suture. Just give loose sutures and bring them nearer. You don't have to go.
I would do that. That is what is known as this Marsupialization of the wound.
Hello.
Yes.
We are shifting to audio in OT1. Dr. Parvesh Sheikh, sir.
Okay.
Yes, doctor. Please tell me.
Yeah, can you hear me, Shekhar?
You can identify yourself and ask the question directly.
Shekhar, can you hear me?
Yeah. Parvez, yes, please.
Yeah. So now you can see this picture. I will show you forceps subject first. Forceps. I'll show you the anatomy well now. This is the mucosa up here. This is the internal sphincter. Okay?
Okay.
Oh, that mucosa. Okay, this is the internal sphincter. This is the anorectal ring. Can you see the anorectal ring very well?
Ask that person to retract it laterally properly. Yes. Yeah. Now you can you see people, all the delegates, can you see the anorectal ring deep inside?
I'm showing you the proper anatomy. The mucosa here on top. This is the internal sphincter. Can you see this internal sphincter?
Right.
This is the external sphincter. This is the deep part of the external sphincter. This is the superficial part of the external sphincter. This is deep part of the external sphincter. And this is the anorectal ring. Okay. Now when you do PR examination here, I can feel the anorectal ring. This goes like this, so you can feel. So you keep on palpating the anorectal ring. Now there is a. This is leading to the supralevator space. So this is leading to the supralevator space here. Now the space is very big. If the space was not big, I would have excised it and I would have sutured it like this. Okay, this would have gone like this. But because I need access to that space, I will just suture some part of it, but keep the excess still there. Because the dressing will become
easy. Is it intersphincteric space? Because then you are gone up to the above.
Yeah, that's why I said internal sphincter, external sphincter. This is the intersphincteric space, but now it is leading to the supralevator space. So it's a horseshoe, okay, horseshoe. So what I'm going to do, I don't want to close this because this will become very, there will not be access for this.
Yes.
Because daily we have to flush and pack this. So I'm going to suture some part of muscle so that to make the tone better, at the same time keep access for this. So ideally we should have, we should suture with PDS suture. but now we don't have PDS. So now you can see this. This is internal sphincter, okay, where I'm taking my needle.
Okay.
This is the deep part of the external sphincter. This is the superficial part of the external sphincter. Okay.
Right.
So I'm suturing that.
This is Vicryl or PDS?
We don't. Ideally, it would be PDS, but PDS is not there. So I'm suturing with Vicryl.
Dr. Parvez, sir.
Yeah.
In this area, you have not cut down the sphincter. So can you just lay it open as far as the recurrence is concerned? And what is the rate of recurrence if you suture it and if you do not suture it?
No, recurrence will not happen whether you're suturing or not. We just need to keep access to that space. That's all.
Can a retained suture act as an nidus for the recurrence of the infection?
No. The suture is not responsible for recurrence.
Okay.
See, I have removed the entire disease. Even from here, this was a tract which was obliterated. It was going up to here, but the communication is obliterated, so I'm not opening up the communication, but the disease is out here. So in this patient, I've excised the complete disease. There is no disease left behind. Everything is out. Also here, if you see whatever I have cut laterally, okay, so that part I will try to suture a little bit. Although, if you the test is you do a rectal examination, feel for the anorectal ring. If your anorectal ring is intact, you don't need to bother.
How many of you would like to handle such case on your own? Please raise your hand. You would be able to handle such case? Congratulations. We have got many daredevil surgeons here.
The idea of doing a workshop is to see that people get confidence and start doing surgery. But these type of cases are difficult for any surgeon for that matter. So it is better that you take the help of an experienced colleague when you start doing these cases. Once you have done enough, then you don't need to bother.
Or call at least one other surgeon who can help you in assisting in finding the proper anatomy. Otherwise, if you keep on remain dependent on your assistant who doesn't know what to show and
so whatever muscle I've cut laterally, I'm suturing it. Are there any questions, Shekhar? Is the surgery seen well?
went very well, and even Parvez, even I was scared when you were going deep inside. But there are many daredevil surgeons. They said they would be able to do it on their own. So hats off to them. Thanks to the workshop we have been organizing. We keep on learning new things. Even Dr. Nisar showed very difficult and very rare case.
Yeah, he's also shown a good difficult case.
Excuse me, sir. So this is Dr. Shashank from Gurgaon.
Yeah.
I wanted to ask Dr. Pravesh Sheikh, what are the imaging findings you would go back and confirm that, yes, the whole disease has been excised?
No, you can see on the table itself, right? Whether everything has been excised.
Yeah, what is the information you would want from the radiologist to ensure that the
from
whole
the
disease...
radiologist?
Yes.
Well, a radiologist should be able to tell you what type of tract it is, transsphincteric, intersphincteric, if there are any branches, whether there are any associated abscesses, supralevator extensions, and in real time. And you should draw a diagram which is easier for us as surgeons to understand. So my radiologist does that. And if he has any doubt, he calls me up and discusses the case with me.
Parvez sir, this is Vivek from Jamshedpur. I would like to know what preoperative counseling, given the history of the case, would, before taking such cases, we should sit up and discuss with the patient?
So I tell the patient after examining that what procedure I'm going to do. And then about that procedure, I tell the patient that in the literature, this particular procedure has a recurrence rate and an incontinence rate of this much. And in my hands, the recurrence and incontinence rate is this much. And what to expect post-op, pain, he needs to do dressing properly. All those things I need to explain to the patient beforehand. So the patient is mentally prepared for all the things which happen post-op. Also, I tell them now, like if I do fistulectomy with sphincter repair, I tell them that I cannot assure them, I cannot assure them of flatus incontinence. Some of the patients get flatus incontinence, which you can get after this sort of surgery, but 30% of them get that, and out of that, half of them do recover that, but it doesn't affect their day-to-day life as such.
Hello, Parvez sir.
Yeah.
Dr. Nilima here.
Yeah.
Would you recommend colonoscopy in such cases pre-operatively, or at least see if fecal calprotectin?
Well, depends on, see, if the patient is a recurrent case, find out what is the cause of the recurrence. So if you're suspecting Crohn's disease, then multiple openings or inflamed mucosa or, abdominal symptoms, weight loss or loose motion, diarrhea, all these things are there, then one would better to do a colonoscopy. But if the fistula is because the incomplete previous surgery, then that doesn't justify.
So we can see pus coming out from the supralevator space.
Yeah, supralevator doesn't mean Crohn's. Supralevator I get so many. Almost every OT I do on supralevator. So that doesn't mean anything. Supralevator is not indicative of Crohn's.
No, but to rule out.
But rule out, if you are suspecting, if you have any doubt, there is no harm in doing a colonoscopy. But what I'm saying is just because it is recurrent doesn't mean that it is a Crohn's disease. Or if it's a supralevator fistula, doesn't mean it is Crohn's disease.
Rather than colonoscopy, CT would be better in the supralevator abscess.
Or fecal calprotectin.
Yeah, fecal calprotectin you can do if you're suspecting that.
Yeah, thank you.
So well done, Dr. Parvez and Dr. Nisar. Can we have a good round of applause for both of them, friends? So Parvez and Nisar, it is for both of you. Both of you have done excellently well.
So now, Shekhar, if you see, I have left this space open here for flushing, okay? And so post-op, we'll just wash and we'll flush this space and just keep a gauze here. Okay, this is the ischiorrectal fossa. This is the gluteus muscle here actually. And so what I say is R0 resection of the fistula tract or F0 resection of the fistula tract. And also we can inject some methylene blue at the end here and just pack. You can just pack the wound. Okay. Okay, thank you so much.
Parvez sir, would you like to put a drain there in the cavity?
No, the cavity is open. We'll put a pack of betadine gauze pack. Betadine.
Dr. Nisar has used a silk suture or Vicryl suture?
I will just put a pack here.
Parvez, if you have time, you can show where the methylene blue is injected.
Methylene blue ampule share?
You can just show us where the methylene blue is injected.
Okay, I'll show. I'll just inject this. Methylene blue ampule, 1 cc methylene blue ampule માંથી છે કે એમાં કઈ બીજું કઈ મૂક્યું છે એમાં? નહીં, પ્લેન methylene નવું લઈ લો. એક 10 cc સિરિંજ લેજે, 1 cc methylene blue અને 5 cc bupivacaine. 0.25 છે, 0.5 સેન્સર કેન છે. હા, સ્પાઇનલ માટે એબ્રોડલ માટે આપે છે ને 0.5. 5 cc bupivacaine and 1 cc methylene blue. So I'm taking 1 cc methylene blue and 5 cc of 0.5.
5 cc of bupivacaine.
આ નહીં, normal
or lignocaine.
આ ગોઝનો આવે છે ને, ટેપ આવે છે ને તો આ પણ ચાલશે. betadine ખાલી આપજે.
So there is one question from one delegate. Yes, doctor, please identify yourself.
1 cc લેજે.
Parvez, Dr. Pankaj from Surat.
Yeah.
Pus for culture and biopsy, histopatho, any help?
Histopath is a must. You should do. Now we don't know whether it's tuberculosis or something else. all cases of fistula, we should send for histopath. Okay, pus for culture is not necessary because there is no role of antibiotic. We don't use antibiotic post-op. नहीं यहाँ तो 5% है ना for epidurally use ना 0.5 ये आपको 5 cc है वहाँ बुपिवाकेन बल्ब में आवे છે 0.2
Meanwhile, on Nisar side, Nisar, audiovisual, can you please take us to that side?
0.2 हाँ तो 5 cc है ना 1 cc में फिल्म लो
Hello, Professor Nisar. Audiovisual. Can you take us to the another OT, please?
છે કે સિરિંજ સસ્તું છે
Okay, we're done. I'm
Dr.
done.
Nisar?
Nisar.
Yes, sir.
Any advantage of applying these features if you leave it just open like that? Then also the wound will contract.
It increases the wound healing, right? It reduces the healing time, right? So number 2, it will avoid these side pockets in which the debris will collect, and the dressing will also be easy. See, I will show you just now. Yellow.
Dr. Shekhar?
See, now this wound is absolutely open and it is unlikely to get infected. Now it will heal by granulation and fibrosis and epithelialization from the side edges. Right? So
But still
absolutely
the fecal
nothing.
matter, it is powdery. It can go from any side, anywhere, even
Which
by
one?
the side of the suture.
Which one? But it is
Fecal
less
matter.
likely now. Once you stitch the wound, it is less likely. It has been shown that this marsupialization of the wound definitely helps in what you call as healing, and it improves. Now wound looks better rather than open like this. Edges should be always shelving in a wound. That is
one
the principle
question.
of the wound healing, right? They should be shelving. They should not be undermined or like this, elevated. So it is always better to have a wound like this with shelving edges. So I am almost done now. So I will put a light dressing here only, just a gauze pack. That is all.
Can you apply little more loose sutures on at the 6 o'clock position to make it little narrow? Or
Okay,
you
you
would
mean
like to
here?
leave it open?
But there will be tension if I do that. So I think there will be tension. I don't want anything under tension. So I would only do that thing which is without tension. So there is tension, so this suture will give way, because once the patient will sit on the pot, so there is going to be tension and it will open up. So it is already open. It is a minor wound. It is not it is an external wound. So nothing to worry about.
There
this
won't be
wound.
any
Give me
breaching of
back.
the wound and any collection, right?
Give me back.
One question.
Dr. Shekhar?
Jelly back.
Dr. Shekhar? As far as marsupialization is concerned, as we were discussing,
नहीं,
one
बड़ा
is
वाला
this
नहीं,
decreases,
मतलब anal
it
small
makes the
नहीं,
wound
single
more
gauze basic.
superficial. Other two advantages, number one is there is less chance of bleeding, secondary hemorrhage later on, and there is less decrease in squeeze pressure after 3 months if you involve the internal sphincter in the marsupialization or the external sphincter component while you repair it. If you leave the wound open and if you do the marsupialization, less decrease in squeeze pressure after 3 months. This is the literature.
One question to Dr. Parvez. I am Dr. Jatin Gupta from Ahmedabad. Before giving methylene blue, would you suggest
You have Sucrol and cream?